Welcome to this presentation focusing on specific acoustic mechanism at the pulmonary air-tissue interface with regard to its safety implication. My name is Frank Wolfram from the SRH Lung Cancer Center, Gera. FOSS is a fantastic non-invasive treatment modality due to focal accumulation of mechanical energy. Despite the wide range of established treatments, emerging targets arise, such as the heart for aortic valve stenosis, the upper liver dome for metastatic treatment, and some preclinical trials even investigating ablation of thoracic wall in mesothelioma models. During thermal or mechanical FOSS ablation in proximity to lung, the alveolar tissue interface can be exposed by prefocal or postfocal intensities, depending on intonation path, transducer arrangement, and anatomic location. In contrast to other solid tissue, lung is very sensitive to mechanical forces due to their thin structure and the high mechanical activity. In particular, the epithelia cells of the vasculature and the type 1 pneumocytes, separating the vasculature from the air space. It has been investigated well that mechanical waves, such as from blast, can induce breakdown of the alveolar air tissue interface at pressure levels already between 1 to 200 kilopascal, causing severe capillary pulmonary hemorrhage. The effect of diagnostic ultrasound to induce this capillary hemorrhage has been intensively investigated on a pathological level at various animal models, including pigs and monkeys. Even though capillary hemorrhage looks severe, it is generally asymptomatic, not causing any rupture, and is reversible. The most common concern is related to diagnosis because the increased density of lung induces pathological sonographic features that falsify the diagnosis, such as a white lung syndrome. What mechanism causes capillary hemorrhage? Cavitation was early investigated, but the results from O'Brien showed no changes in capillary hemorrhage thresholds at different ambient pressure. A more recent approach from Miller investigating the influence of radiation pressure, which is added to the physiological pressure, show more promising correlation with the capillary hemorrhage thresholds, but remain not entirely investigated. This approach also requires to include the physiological condition of lung. In summary, the central mechanism remains unknown and is therefore not fully predictable. The capillary hemorrhage threshold of diagnostic sonography on lung tissue have been intensively investigated by Doug Miller. This work revealed a threshold in the range of 1 to 1.5 megapascal peak negative pressure, depending on imaging mode. Exposure time seems not to have a large influence on the extent. It is therefore more a threshold phenomenon, and the duration has more an influence on capillary hemorrhage depth. Situation in the therapeutic regime is quite different. Due to the lower frequency, larger transducers, higher amplitudes. The likelihood of capillary hemorrhage in lung is therefore higher. Some literature report in preclinical studies targeting the myocardium with pulse ultrasound reliable detected pulmonary hemorrhage in adjacent lung tissue. Interestingly, this threshold found is very similar to what we know from diagnostic ultrasound around 2 megapascal negative pressure. Other studies investigating histotripsy in the liver showed mild lung hemorrhage, but in almost all animals. Also, lung-related adverse events in clinical studies requiring chest drainage and prolonged hospitalization have been reported. So there is already some evidence that during preclinical and clinical application of therapeutic ultrasound, pulmonary capillary hemorrhage might be induced. To avoid any lung involvement, treatment planning should exclude, first of all, any direct exposure of the pleural surface. Then rupture and tissue erosion could lead to severe events due to total acoustic reflection, as shown by Simon. Only a few studies reflect safety margin at the air tissue interface. Here demonstrated using a plot cloud model. The assumption is given that no damage to the interface appear when there is no rupture or ablated area below the air tissue interface. But this assumption is not valid for lung, where capillary hemorrhage occurs at the acoustic intensities below thermal and mechanical effects. The threshold and extent of capillary hemorrhage can be manipulated when mechanical ventilation is performed simply by applying a positive end expiratory pressure. Preclinical work showed that this can increase the capillary hemorrhage threshold to values above 2 megapascal and reduce the extent. Lung can be also detached from the pleural cavity by installation of air and saline or saline, inducing a controlled pneumothorax or effusion. But this procedure requires a good monitoring and drainage with a certain risk of re-expansion hemorrhage. Finally, one lung or a part of it can be filled endobronchially with saline, which induces acoustic accessible lung tissue without remaining air. As our group demonstrated in earlier work, transpulmonary FUS at the entire upper liver dome is feasible without any damage to the lung, even if the focus is targeted directly into the floated parenchyma. No damage occurred up to 10,000 watts per square centimeter, even in the presence of cavitation. But this method requires a one-lung ventilation and a good training. Let's summarize this huge amount of information. Awareness should be paid by the FUS operators and researcher to the mechanical sensitivity of the vulnerable pulmonary air tissue interface. Therefore, the main sonographic society already recommend a mechanical index in the range of 0.3 to 0.7. FUS is a fantastic, non-invasive, non-radiating treatment modality for many diseases and conditions, even though in the therapeutic regime a certain impairment of adjacent tissue is acceptable. To strengthen these advantages, adverse events needs to be recognized and methods developed to reduce their extents. This has been done, for instance, for skin burns as the most common early HIFU-related adverse events by inventing cooling discs and pulsing schemes. In the future, treatment planning should monitor intensities around the pleural surface and optimize the insonation part. If there are researchers or clinicians uncertain about the likelihood of exposure of lung, feel free to contact me or the FUS Foundation. They can put you in contact. There are several ways to minimize the risk, depending on application and patient condition. Thank you for your time, and I would like to thank my colleagues from the SRH Wald Clinic as well as the ECMO Safety Committee, and hopefully seeing you in Maryland soon.